How Good afternoon, everyone. Welcome to the last session of the first international conference on the science of language in the brain. We hope that the presentation so far has been informative and engaging for all of you. Now we have arrived at the final panel, which will delve into the vital field of clinical linguistics and language pathology. This panel will provide a seamless transition from the foundational and theoretical aspects of brain and language research to the more practical and applied aspects that have significant societal value. It is worth noting that although clinical linguistics and language pathology are highly interrelated, they have distinct natures that set them apart. Clinical linguistics is a branch of linguistics that deals with the application of linguistic concepts, theories, and methods to study the language disorders. It is an interdisciplinary field that combines knowledge from linguistics, psychology, and neuroscience. And clinical linguistics aims to understand the nature of language disorders and the factors that contribute to them and the most effective ways for treatment. On the other hand, language pathology, also known as speech and language pathology, is a field that focuses on diagnosis and treatment of communication and swallowing disorders. Language pathologists work with individuals across all ages with range of communication and swallowing disorders, including developmental and acquired language disorders, fluency and voice disorders, speech motor control, and dysphagia. And the speech pathologists use variety of treatment, assessment, and treatment techniques to help individual to improve their communication. All right. With this introduction, I would like to introduce our keynote speaker, Professor Roelien Bastiaanse. She is an esteemed. I hope that I didn't butcher the name.
No, it's perfect.
So Professor Roelien Bastiaanse is an esteemed neurolinguist professor at the University of Groningen in Netherlands. She is a pioneer in the field, and he has co-founded the Science of Aphasia Conference and several prestigious and advanced multi-university programs in clinical linguistics, including the European Master Program in Clinical Linguistics and International Doctorate for Experimental Approaches to Language and the Brain. Roelien is a linguist expert in aphasiology with a focus on studying cognitive aspects of language, particularly syntax and acquired language disorders such as aphasia. She has a niche and continuous research line related to the verb processing and its neural correlate across different languages. Her valuable and pioneering contribution to the field of neurolinguistics have earned her the title of Mother of Neurolinguistics by the Dutch news platform during her retirement ceremony last year. Despite her retirement, she remains highly active in research, which is remarkable and admiring. I personally have the privilege to meet her in the summer neurolinguistics schools in Moscow in 2017, and we had a great discussion about the action verb processing in Persian speaking with aphasia. So at this conference, Professor Roelien Bastiaanse will be presenting her latest research regarding the brain tumor patients. And her title of presentation today is Language Testing in Brain Tumor Patients, What, How, and When. So without further ado, I would like to invite her to present today. Just want to add something that due to the tight schedule, I might need to remind you of the time 5 minutes before the end of presentation. Thank you very much.
Okay, thank you very much for your very, very kind words, and thank you, Farnus, for inviting me. Let's see how this works. So, as you can see, I changed the title a little bit to pre-surgical language mapping. What are we testing? What are we exactly doing when we are using pre-surgical language mapping? Okay, and when do we use it? So, the first thing I'm going to talk about is how we retrieve a word on a naming test. So you show a picture to the patient or the person and you ask what's in the picture, for example, a tree or a house. And how does this work? And which areas in the brain do we use for that? And then I will go to the mapping, the TMS mapping. How can we disrupt this process? And then I'll give the results of one of the studies we did. I did together with Annie Olert to verb and noun retrieval in pre-operatively in brain tumor patients. Okay, first, how do we retrieve a word? In the OR, the operation room, the operation theater, usually if there are pictures used, picture naming is used, then they show a picture of, for example, a cat, and then the patient has to say cat. But how does this work? Which part of the brain are involved when you identify the picture, when you activate the word cat, and which parts do we need to articulate the word? So retrieving a word is a whole process. It's not you see a picture and there is the word. A lot of things are going on in different places in the brain. So if you think of a cat, and if you can do that now, just think what's the size, what's the color, what's the shape, and what sound does it make? How many legs does it have? Does it have a tail? How does it feel? Do you like cats, for example? And then you have a picture in your head of a cat, and it must look something like this. These are different kinds of cats: sweet cats, strange cats, red cats, etc. But it does not look like, no, it may even look like this, but it does not look like any of this. So if you think of a cat, and I asked you, think what size, color, shape, so that's visual information. That's stored in the visual cortex, in the occipital lobe, bilaterally. So it has nothing to do with language. If you just think of a cat, it has nothing to do with language. If you think about the sound that is made, this information is auditory information is stored in the auditory cortex. So that's temporal lobe bilaterally again. If you think how it smells, you need your olfactory cortex, and that's stored in the temporal lobe again, bilaterally. So all this information is stored bilaterally. Same, what does it feel like? That's sensory information, that's in your sensory cortex, that's the purple one here. Again, bilaterally. So, and if you think, what does it eat? It's your semantic memory, it's your hippocampus, but also the frontal and the temporal lobes. And if you think about whether you like it or whether you hate it, this emotional information is stored in the amygdala, just under the temporal lobe again. So what you see is that all this information together that forms the concept of a cat, because you do not have just a concept of a cat, but immediately you activate what it looks like, what it feels like, etc. And that spread over your whole brain, over both hemispheres. So it's important to keep that in mind, because I will come back to that later. Now, if you have to name a picture of a cat, you first have to, of course, to retrieve the concept. And then you have to activate what we call the lemma. That's the underlying abstract word form that contains information about the meaning of the word, about the word class. A cat is a noun, it's not a verb or an article. It's not a word yet. So it may very well be that the lemma that I have for cat is the same as the lemma that you have for cat. It's just the abstract word information. So, and how are lemmas stored in the brain? Well, we can do another test for that. Just, if I say cat, what's the first word you think of? And I usually do this in a class, and then I ask the students. Now I can't do it, but I'm quite sure that many of you thought of a dog. And you do that on the basis of the meaning. So it means that the cat, the lemma cat, is stored very closely, and closely is of course not measurable, but it's very closely to the lemma of the dog. And if you activate the lemma of the cat, many other lemmas are meaning-related lemmas are co-activated, like dog, like mouse, like mewing. And these co-activated lemmas are inhibited, and the lemma of cat wins in a healthy brain. So where are these lemmas stored? And all this information I give you on localization comes from a very important paper from Peter Indevrij, 2011. You see it in the lower right-hand corner, who did a meta-analysis of all the studies, MRI studies, the TMS studies, ERP studies, all things like that, where he gathered information on which process takes place. It's on the basis of hundreds of participants in several languages. And he found that in the middle part, I hope you can see my cursor, that in the middle part of the left middle temporal gyrus, the lemmas are stored. And this is only in the left hemisphere. Once the lemma has been activated, you activate the lexeme cat. And lexemes are the underlying word forms, the phonological word forms. And they are stored on the basis of their sound structure. So the lemma activates the lexeme, same as it just did before. It activates the lexeme. Closely related lexemes, like fat and red, are co-activated. And again, lexeme cat wins in a healthy brain. So this whole idea of activation, co-activation, inhibition goes all through the brain. Okay. The lexemes are stored in the posterior part of the left superior middle temporal gyrus. So again, left, it's more or less Broca's area. Wernicke's area, of course. I will show you later the exact location. After the lexeme has been retrieved, the correct phonemes have to be filled in, and they have to be filled in the correct order, and the phonological rules have to be applied. So the lexeme cat, you fill in the K, the E, the K, the E, and the T, and then you get cat, and you apply the phonological words where you assemble all the phonemes to a word. This phonological encoding is done in the left arcuate fasciculus. So that's a connection basically between Broca's area and Wernicke's area. So you retrieve the word and then you fill in the phonemes and you have to bring it to Broca's area. What are you doing there? In Broca's area, you are going to plan and program the articulation. So it's not the actual articulation, the motor activation, but it's the planning and the programming of articulation. And this is on the interface of language and speech. So you program the articulation of the individual sounds, speech sounds, but also this takes care of a smooth transition from one speech sound onto the next and from one syllable onto the next. So here all the assimilation processes take place. So you do not say cat, but you say cat. Where do we do that? Well, we do that in the left inferior frontal gyrus, it's known as Broca's area. And then we can finally articulate the word. And for that, you need your left and right, again, motor and sensory cortices for your mouth and neck, just before and after the fissure of Rolando. And then, only then, you can finally say the word cat. Now here you see that it's a long process that you do in about less than a second. So just to recap, you do the visual analysis bilaterally, then you recognize the concept all over your brain bilaterally. You retrieve the lemma in the middle part of the middle temporal gyrus. You retrieve the lexeme at the posterior part of the middle and superior temporal gyrus. Then it's brought to the front via the arcuate fasciculus. Then you plan and program the articulation in Broca's area. And finally, bilaterally again, you can articulate the word. Okay. How? Well, this process is easy for us. We can easily name a picture of a cat, but not everyone can. People with aphasia, for example, I assume that you all know that aphasia is a language disorder, may not be able to retrieve the word. And we may like to disrupt this process to find out where exactly the activation of the lexeme lemma, etc., takes place. Why is this relevant? I mean, you can say we know it already. Well, it's relevant in case of brain tumors, because brain tumors infiltrate in healthy tissue, the ones that I'm talking about. And the neurosurgeon, he would like to resect, or she, but usually it's a he would like to resect as much tissue as possible, but leaving all the vital functions intact. So as a neurosurgeon, you do not want to cut away the tumor and one of the language areas, because then the patient cannot talk anymore and cannot communicate anymore. And then the quality of life severely diminishes. So, in order to resect as much tissue as possible and leave all the vital functions intact, you need to know what the functions are and where and how they are represented in the brain. If you do not know what a lexeme or a lemma is, you might cut it away, and if you do not know where it is. So, before surgery or during surgery, you need to test all these functions. So, how can we disturb this process? During brain surgery, nowadays, the patient is awake. The patient is awake, well, he's woken up, and then language test and other tests can be done. So as I said, you try to resect as much as infiltrated brain tissue as possible, and you avoid to resect what we call eloquent, so talking areas that are crucial for language. So the patient is woken up. They use direct electrical stimulation, so a very low electrical current on the brain that inhibits the function of that part of the brain. Now, if you do that, if you ask the patient to name a picture of a cat, and he can do that when you activate, when you use DES, then that area is not important for naming a picture of a cat. If all of a sudden the patient cannot name the picture of a cat anymore, it means that this is a vital area for naming pictures. So, and that only lasts for 4 seconds, so don't worry, it's not that they do it permanently, of course. There is another method that is getting more and more popular in addition to direct electrical stimulation nowadays, not in place of, but maybe in the future, who knows, when we just manage to improve this technique, all the techniques, by the way. And that's called NTMS. That stands for, TMS is transcranial magnetic stimulation, and N stands for navigated. So you can give a brief pulse of high-strength magnetic field through the brain, and Farnoosh knows much more about this than I do, by the way. I'm just a laywoman. And you do that through the skull on the cortex. So you can do it with me as well. You don't need to open the brain for that. It's about 5 to 10 hertz. And that depolarizes the cellular membranes. And then the activation is disturbed. Activation in the brain is disturbed, and then you get an inhibition of function. And now I wanted to show you a clip how that works, but I can't. So what you can do, you activate, you use this NTMS, and all of a sudden the patient cannot, or the person cannot name the picture anymore. So this is an alternative way for language mapping, and we know that if you do this pre-operatively, this NTMS testing, then you can enhance surgical planning. So it's better to plan. It shortens the intraoperative procedure, so where the patient is awake during surgery, so that's less stress for the patient, but also for the surgery team. But I can tell you, I've been in the OR testing patients, and it is a very stressful situation for everyone. You can reduce the size of the craniotomy, so that the size of the piece of skull that has to be removed in order to approach the tumor. But also, you can prepare the patient for intraoperative loss of speech. you can tell, otherwise you can tell them, well, I'm going to test you during surgery, you see pictures, and then all of a sudden you can't name them anymore. But you can also let the patient experience it, and that may give less stress than during surgery. And even better, there are of course patients you cannot who cannot endure awake surgery, like children, for example, or psychiatric patients, and they also get brain tumors. And then you can use NTMS instead. As I said, it's not as good as DES yet, but it's getting better every year. So here you see how it works. There is this navigation system, the figure of 8 coil, that's this, that communicates with the infrared camera. If you cannot see my cursor, then it's of no use that I show this to you. You have the MRI or CT of a subject, and that's aligned with the physical head, and you put the coil on the head, and you can very, very, very precisely, millimeter-wise, inhibit the function in the brain. And then here you see a picture of an apple. This is the picture that the patient sees and has to, or the person sees and has to name, and everything is videotaped. Okay. So what are the advantages of NTMS? Well, you can visualize the cortical regions on the screen. You can see that you can adjust the strength and the direction of the magnetic field. So you can very precisely pinpoint to the targeted cortical regions. And you do that in real time. It's safe and it is tolerated as long as you do not stimulate the visual cortex or the very frontal parts of the temporal cortex. In order to do this, you need a very cooperative participant or patient who can directly give feedback. You should have a task that can be carried out within 4 seconds, both for DES and for TMS. Although maybe for TMS it may be longer later when we know more about it. What you do before you do TMS testing, you do baseline testing. So you have a test of, say, 40 items of nouns, apple, cat, bat, whatever. And you ask the patient to name all these pictures twice. And pictures that he cannot name, you throw out. Then you do the NTMS testing with the pictures that the patients can name, so that you can be very, very sure that the patient is able to at least name these ones. So if they cannot name it, it is due to the NTMS and not because the patient doesn't have the word. Everything is videotaped, so afterwards you can score it. So what are the pros and cons of NTMS? Well, the pros are that there is a very high correlation between the NTMS maps, so the one that you do pre-surgically, and the direct cortical stimulation maps that you do during surgery. So that means that you maybe later on we can replace this very invasive DCS by the non-invasive NTMS. It's very sensitive, it is very specific, it has a very good predictive value for negative signs. So if you do not find a sign, if you do not find place in the brain during NTMS, you won't find it during DCS. And it is very, very superior to fMRI maps. Unfortunately, it's still less convincing for positive signs. So if you find a positive sign during NTMS, that doesn't mean that during DCS, the same spot will also be positive. Nowadays, that is still assumed that that's because NTMS is not as predictable as DES, but it may DCS, but it may very well be that direct cortical stimulation is the one that is not as precise as NTMS. We do not know that yet. And although we are getting better and better every year, the exact parameters are still unclear. So when exactly Do we have to give this pulse? I'll come back to that. What should be the frequency of the pulse? What should be the duration of the activation? What should be the intensity? And all these protocols have not been validated. We have some ideas, but it's still in its infancy. So the NTMS studies to language, what did they reveal? There are several groups who do this. One of the groups is the group of Greek, and he made a detailed protocol with a very nice error analysis. It's a really nice paper, but he only did it for object naming. And then Hernandez Pavon, he used both object naming and action naming, but action naming was an infinitive in isolation. And well, as you know, in Farsi, for example, you have to inflect the verb for tense, agreement, things like that. But what this group found was that object naming is less sensitive than action naming. So if you do action naming, you get more positive spots than when you do object naming in NTMS. By the way, it's exactly the same by direct cortical stimulation during surgery. So, as a linguist who likes verbs and who doesn't like nouns so much, because I think that verbs are far more interesting than nouns, and I know that there are a lot of linguists there, and I think they will agree with me. As I said, during surgery and also pre-surgical language testing was always focused on nouns. However, verbs are the core of the sentence. You can easily have a sentence without a noun. You can't have a sentence without a verb. So what we did, we developed a test for both nouns and verbs. It's called the Verb and Noun Perioperative Test, the VANPOP, and it was developed by Annie Odet and me. The paper is here on the slide. We match the verbs and nouns on relevant factors like word frequency, like imaginability, like age of acquisition. And other than many other tests, most other tests, we put them in sentence context. So you do not use verb in isolation, or hardly ever, at least in daily life. You use them in sentence context. So we used action naming test with inflected verbs and object naming with an article and a noun. And we have now German, Dutch, and English versions standardized. So this is the noun test. You see a picture of a bird, and then it says this is, and the patient has to say this is a bird. Or in German, you also have to inflect the verb for a case and gender. Production of finite verbs in the English version, every day the man fishes. Okay. And the research questions for this study was, should we use action naming as well as object naming to find positive language areas when we use NTMS? And can we detect different cortical areas involved in the two tasks of language mapping? So is it maybe the case that, for example, nouns are more posterior in the brain, whereas action verbs are more anterior in the brain? So for this study, and this is only about healthy participants, if you want to know more about tumor patients, read the papers of Annie Odet. We first did baseline testing, as I said. We first wanted to see whether in this case, students did recognize the pictures and could find the words, and then we did NTMS language mapping. And now, this is really a pity, because this is a very nice clip of someone working with Farnoosh, and here he is saying in German, das ist ein Käse. Das ist ein Käse. And in the next clip, he gets NTMS, and then he says, das ist ein Käse. So that's slurred speech. You see, I have several of these clips. You see on these clips that he makes errors when NTMS is used. Okay, This is a multi-center study that we did together with the Technical University in Munich and King's College in London. And here I presented German data. It doesn't really make a difference. So what did we do? We NTMS'd the whole brain except for the visual cortex and the prefrontal cortex and the pretemporal cortex. We first got data from 2 baselines, and then each point that you see here that has a number is mapped 3 times, and each hemisphere is mapped twice. So it's the first study actually that did it this way, both nouns and verbs. Very intensive testing and in each hemisphere. Okay. We had 20 healthy participants, and the research question was, as I said, are object and action naming equally sensitive, and are there specific areas for object and action naming? This is object naming and action naming in the left hemisphere. So they do not make many errors, but in the dark areas, they make 13 to 15 errors here for verbs. And what you see overall is that the action naming hemisphere is greener than the object naming hemisphere, meaning that more errors are made for action naming than for object naming. So it's far more sensitive. Strangely, what we did not expect is that we found more or less the same in the right hemisphere. Also here, much more errors were made with verbs than with nouns. In the right hemisphere, that's not supposed to host language. I will come back to that. So, but what we did find is that there are more errors made. There were more errors made for verbs than for nouns, but the sites are the same, right? There are some sites that have significantly more verbs than nouns, but not that you can say, here are the verbs, there are the nouns. But what surprised us most was, of course, that there was no difference between the left and the right hemisphere. And also, because you can go back and go through all the whole procedure, because it was videotaped, we analyzed the error patterns, and what we found was that most errors were hesitations. So that is, this is, and then they waited a moment, and then they gave the name, or performance errors, articulation errors. That's both 30%. And keep in mind, articulation is bilateral. So what's going on? At the group level, the word production process can be disrupted in both the right and the left hemisphere for both verbs and nouns. And this confirms that the positive sides are not very reliable. This is at least what the neurosurgeon said, because we know that the right hemisphere does not host language. If you get a stroke in your right hemisphere, 99% chance that you will not have aphasia. Okay, now I'll give you some possible explanation. I have a favorite one, but I think I'm the only one who favors that explanation. This is the explanation that the neurosurgeon liked most. So he says there is a language network, and it's spread all over the right and the left hemisphere, and it's connected through subcortical tracts. You can disturb it by NTMS, but when you have damage to the right hemisphere, there is enough, the network is sufficiently activated to function adequately. So there is language in the right hemisphere. It's part of the network, but it's less well rooted. So even if you have a stroke in your right hemisphere, the left hemisphere can do the work. Though not with TMS. That's surprising, I think, but okay. A second explanation is that there is a learning effect. Notice that we did 2 baselines, and then we did NTMS, and so at least 6 or 7 or 8 times. It means that each item in both tests has been named 9 times overall. Well, that's a lot. Now, there is a study to the learning effects of verbs, a study by Weber et al. It's a German study, and they studied learning of new verbs, so non-words, new verbs. And they did an fMRI study. And what they found is that when the participants were learning the verbs, that the left hemisphere and the right hemisphere, and even more the right hemisphere, was involved. So what you see in the fMRI here is the number of verbs, novel verbs that were repeated, minus the ones that were not repeated. And these areas are very similar to the areas that we found. So maybe we just used too many, we used the verbs and the nouns too many times. Maybe we should have much larger tests, many more items, which is a lot of work, but in order to see whether the right hemisphere is really involved. And for the third explanation, I like to go back to the time course of word production. So this was what I showed you earlier. It's a little different graphic, but what you see here is you have a picture that activates the concept bilaterally, then the lemma retrieval in the left hemisphere, lexeme retrieval, left hemisphere, phonological encoding, left hemisphere, program of articulation, left hemisphere, and then the articulation bilaterally. Now, what we did, we showed the picture, and exactly at the same time that the picture was shown, we used NTMS. Now, unfortunately, IndeVrij did not give the timing for concept activation, but it must be somewhere between 0 and 200 milliseconds. Now, what might have happened is that we just activated too early. And so with the activation, we avoided that the complete concept could be activated. And that explains why you find it in both the right and the left hemisphere, right? So it's concept recognition that we disturbed, not language retrieval, word retrieval or sentence retrieval. So maybe we stimulated too early and disrupted the concept recognition rather than the linguistic steps, which is fine, but we should keep that in mind. And that may explain why we get bilateral errors in both hemispheres. So what supports this is that I said that the number of hesitations is quite high. So these were not linguistic errors, they just needed time to retrieve the word. However, there is this study of Creek et al. That said that you get the best results when you have 0 milliseconds delay. So you get most errors when you show the picture at the same time that you stimulate the brain. You get the highest correlation with DES, but as I said, or DCS or DES, that's the same. As I said, that doesn't mean that there is language in these areas. You get the lowest percentage of post-op, so deficits, language deficit after surgery. But what is the best result, right? So maybe if we stimulate later, it's more precise, the language activation is more precise, and the patient will survive with maybe a little bit more post-op deficits, but in the long run, language will not be disturbed, and you can remove more tumor in that tissue, and that's, of course, important. He also said that you get the most positive areas, but if these areas don't host language, that's not very important, I think. But you hear what my favorite explanation is. Okay, so my solution to this is, and this is a study that we just for which we applied for a grant, and we will soon hear whether we can do it together with Farnoosh. Maybe we should take the time course for word production into account. So vary the stimulation onset time with the timing of the process you wish to disturb. So
Disrupt. There's only 5 minutes left for presentation.
yeah, I'm almost ready. Yeah, that's fine, that's fine. So now we we stimulated when the picture was shown, but maybe if we want to focus on lemma retrieval, so if we want to focus on the middle temporal gyrus, we should have a delay of 200 milliseconds. If we want to focus on lexeme retrieval, we should stimulate the posterior part of the middle and the superior temporal gyrus 300 milliseconds after the picture appears, and so on and so forth. If we want to program articulation, to disturb the programming of articulation, 500 milliseconds, etc. And I think that is a good idea. There is, however, a study of Solman and others, and they got more or less the same results as we did, but that was only action naming, just a picture, name it like cat or house. And he only tested the right hemisphere, not the left hemisphere, but he stimulated 300 milliseconds after stimulus presentation. So I may be wrong, but I would still very much like to try this. Now that we can use stimulation with a robotic arm instead of my PhD student just standing there and stimulating the brain, I think this is worth trying. So I hope you learned something, and I hope the most important thing that you learned is that there are still a lot of other things that you need to know. We do not know yet why the right hemisphere is so easily disrupted. We do not know yet the time course for action naming. I only told you the one for object naming. Nobody ever studied the time course of action naming. We do not know the time course of retrieval of nouns in sentence context. But I'm sure you will get there in the end. I said we will get there in the end. I'm retired now. It's all up to you. But I hope I showed you it's a very interesting area that has a lot of clinical relevance. So the test that I was talking about, the VanPop, it's freely available. You can use it for pre-surgical language mapping, for intraoperative language mapping. You should address me or any OLAT. If you'd like to know more about this, you can join our massive open online course, language testing during awake surgery. Everything I said there is in there and a lot more. You can find it on www.futurelearn.com. And these are the people who helped me to make this presentation and who did all the work. Thank you for your attention. Ready?
Hey, thank you very much, Professor Bastiaanse, for very stimulating and very informative presentation. We really enjoyed that.